a couple of speakers from Imperial College, Dr. Monica Cana, who is a musculoskeletal radiology consultant, and Mr. Dylan Griffin. He's a shoulder surgeon at Imperial College as well. And it's gonna be elbow-related metalwork complications today.
Thanks for inviting me to speak, Marcella, Dimitri, and Elizabeth. So what I'm going to talk about is the elbow-related metalwork complications. I know there have been plenty of talks already on the metalwork complications, and these are the ones I tend to run through when I'm reviewing radiographs, and I'm going to specifically try and concentrate on radiographs. The alignment, of course, of the metalwork or prosthesis, whether there's periprosthetic lucency or cement bone lucency, whether there's dislocation or subluxation. Heterotopic ossification, I think, from my experience, is really important around the elbow because we tend to see it quite a lot around the elbow. And whereas, for example, heterotopic ossification at the elbow will result in really marked reduction in movement or stiffness, flexion or extension. In the hip, you won't see it necessarily reduce range of movement, but in the elbow, it becomes very problematic. And actually, I see more ossification there than other places often. Periprosthetic fractures, and again, infection, where there's any metalwork, we've always got to consider infection. So like I said, what I've done actually is just looked at a few selected cases over the last couple of years and try to just talk around them because these are the sorts of things we commonly see rather than talk about every specific elbow metalwork that you might see. I've selected some where we've had complications and things like that. So let's just start with this first patient. This is an 85-year-old lady with destructive psoriatic arthropathy. This was a radiograph performed in 2015. And you can see there's extensive destruction of the joint, central erosive changes at the radiocapitellar articulation, ulnohumeral articulation, and there's hardly any part of the radial head left. There is some joint line osteophyte formation, which is secondary osteoarthritis. So quite a lot of deformity and destruction there. And you might consider actually in your differential, could this be a Charcot arthropathy if you didn't know that they were psoriatic? But there is sort of reduced density here, which doesn't quite go, but that would be probably in the differential. So this patient actually went on to have a radiograph in 2018, which shows further destruction of the joint. So what did this patient undergo? This patient underwent a semi-constrained cemented total elbow replacement in 2019. Now, I think actually for inflammatory arthropathy in the elbow joints, they will often undergo a total elbow replacement. And this is what we see here. And what do we look for? We also look for the alignment. So the humeral prosthesis has to be within the center of the distal humerus. And on the lateral radiograph, the ulnar component shouldn't come beyond the posterior cortex of the distal humerus. You'll see that there's this ulnar stem and also this humeral stem. And in this case, there is no radial component. So in terms of inflammatory arthropathy, the radial head will typically be excised, and you will get a synovectomy associated with the procedure to treat the inflammatory arthritis and also decrease pain. You'll notice actually on this lateral radiograph that they've actually also developed some heterotopic ossification. That's what we should report on the radiograph because that may extend further and result in reduced range of movement. So let's just talk a little bit about the semi-constrained total elbow replacement. It's a semi-constrained arthroplasty, so that's what you can put in your report if you see something like this. It's a hinged joint, partially hinged is the most common design. It's made typically of titanium or cobalt chromium with metal stems, and you have this bushing mechanism here, and this is metal, and between those you will see the polyethylene, and this is polyethylene lucency between the hinged stem, which will be either side of it. And it is thought that that is is good for reducing the metal on metal friction between the ulnar component and the humeral components. What is good about this semi-constrained design is it allows about 7 to 10 degrees of hinge laxity of the valgus and varus motion. And you'll also notice that these have this big anterior flange at the front. And typically when they put these in, they may put bone graft material in between this anterior flange and the distal humerus. And the reason for this is a design feature designed to decrease stress on the hardware in the AP plane, and also to stabilize torsional rotation. And it's thought that this design may distribute the force between the soft and tissues and the bone, resulting in lower rates of loosening or subluxation or malrotation. So if you see a block of bone here, that bone graft is meant to be there to help this, mechanism. Typically, the survival rates of these prostheses of approximately 10 years at about 90%. Okay, so not so bad. So why do we do total elbow arthroplasties? Well, they are for decreasing pain, restoring an acceptable range of motion to the elbow joint, and the indications that you'll see in the elective setting obviously are rheumatoid arthritis or primary or post-traumatic osteoarthritis, perhaps fracture non-union, or which we'll see in King's College, which is a major one-level trauma center, and Imperial, in the setting of acute comminuted fractures of the elbow, where there's nothing really else that they can do. They can't fix the fracture. Contraindications will include, however, infection, presence of a large open wound. So, for example, in major trauma, if they've got a large open wound, that won't be possible. And also in neuropathic joints. This does not work well with neuropathic. What is the complication of this condition? Well, one of the known complications of this condition is abnormal stem translation. You can see that this semi-constrained total elbow replacement is a different total elbow replacement. You can see that the tip of the humeral stem has translated radially. There's increase in cement bone interface lucency. So this would be consistent again with the loosening we see with other arthroplasties. It can occur at the cement bone interface, as you can see here, or it may occur at the prosthesis cement interface. Now, if you just had the frontal radiograph, you might think that is normal, but it isn't. And you can see on the lateral radiograph that has also ventrally translated through the ulna. So, that needs to be revised. So must look at both views always of arthroplasties to check the alignment. Okay, so we're just going to move on to another case that we saw at Imperial. So this is a 61-year-old lady who came in with an elbow trauma, and these are the sort of typical radiographs you might get, quite difficult to report, not very clear views. They're usually in a back slab, and this is markedly comminuted intra-articular fracture of the distal humerus. You can see here the radius and ulna, and they don't obviously look fractured. You can see that the radial head is dislocated, but they don't obviously look fractured. Maybe a fragment there, but not clear. Typically, these cases will get a CT to assess the fracture pattern further and planned surgical planning. This patient actually underwent an elbow hemiarthroplasty, which you can see here. So not like the semi-constrained total elbow replacement. This is just a hemiarthroplasty, and I presume has been performed because in fact the radial head and ulna were not fractured and they could relocate the radials, and so they just did a hemiarthroplasty. But again, you can see that anterior flange, and that was done in February 2018, fairly soon post-operative fill, because you can see the gas within the soft tissues. And then this is a later film done about a month later, and you can start to see perhaps the formation on the AP view of perhaps some heterotopic ossification. And then as you move through the radiograph, you can see that in fact there is now a big block of ossification at the anterior margin of the hemiarthroplasty, crossing that anterior flange. And it's important that, heterotopic ossification, like I mentioned, is not uncommon around sites of elbow replacement. It may limit the motion in many planes, and particularly flexion. And so it's important as the radiologist to report the heterotopic ossification, where it is, and also the extent of it, and whether it extends even to involve the proximal ulnar, radial ulnar articulation.
Monica, hi,
yes.
it's Dylan.
Hi, Dylan.
Yeah, this case, the main reason we did a hemiarthroplasty, because I was a little bit nervous, because she's only 60, I think, this lady.
Yes.
They've got central
61, yeah.
central comminution, and I wasn't really sure I was going to be able to make a reasonable effort at repairing the articular surface. When I looked at it, she had some bone loss and that kind of thing. So we did the hemiarthroplasty, but it just shows the HO problem is massive with these. And I think there was a series by Dave Stanley, who's done the most elbow replacements in the country, and it was something like a 90% incidence of HO with trauma elbow replacements. Now, that's varying degrees, so it doesn't mean that everybody's blocked, but with her, everything else went well. So we went in, we took away the HO, and now she's doing really well.
Yeah. Yeah, I mean, this is, I mean, I was just saying, I think before you came on, Dylan, yeah, I think one of the things we see most commonly around the elbow is heterotopic ossification, because they present with stiffness, reduced range of movement, and often that's the concern. And this patient actually went on to have a SPECT CT as well, and that shows you quite clearly that there is this heterotopic ossification, which demonstrates increased osteoblastic activity. And I was going to say, Dylan, is it right that we kind of sometimes look at the SPECT CT to see if there's increased osteoblastic activity, because it's when it becomes quiescent that you like to remove it, or what do you feel about that?
That was what we used to do. What I used to do, and I used to take Roger's advice on that, Roger Emery's advice on it.
Yeah.
But there was a paper from China, I think it was, saying that they didn't feel it made any difference when they intervened.
Right.
And so the idea was obviously that there's ongoing activity and we take it away and it reaccumulates. But they didn't find it made any difference, and I've started taking it out earlier now, because it's very hard to leave these people with a completely blocked elbow for a year and a half, or whatever it is. And so I've started taking it out early, and I haven't found much of a problem. They seem to be, I put them on indomethacin after, and they seem to do well from it. Yeah,
I mean, this patient, she had, I'm going to show you the CT, yeah, so she had a sagittal CT, which also showed that big block of heterotopic ossification. But as you say, these are the post-operative radiographs after that's removed, and you've got some consolidation of the ossifications of that anterior flange, but actually that's all clear. She's had a good result. So that's that case of the hemiarthroplasty.
She clinically presented with being really quite happy at 6 weeks, and then to being very unhappy sort of 3 months-ish. So.
Okay. Okay, so I'm just going on to some more cases actually, Dylan. So this is a 33-year-old man who fell on the outstretched hand, question mark fracture, and you can see here that there's an intra-articular fracture through the radial head here. But on the coils view, which is just a more clearer view of the radial head and neck, you can see that's intra-articular fragment which is displaced, and they also actually had a CT which further shows that flipped intra-articular fragment on the CT. Now this patient went on to have a radial head replacement. So here you can see the radial head replacement. The stem needs to be aligned within the distal radius, but unfortunately on the lateral radiograph, this was dislocated. And I think this happened a little while after their replacement date. So the radial head is dislocated, so the patient went back to theatre. So again, just to reiterate, alignment is important, and although it may look okay almost on the frontal view, it's not okay on the lateral view. So they went on to have a revision radial head replacement on the 18th of September, and at this time they also had a lateral ligament repair for instability, because they were thought to be unstable at the time. But unfortunately, about a week after that, they had a CT which again showed a dislocation, and that patient in fact went on to have a radial head resection in the end. So I was going to talk a little bit about radial head replacements. Radial head replacements typically occur for radial head fractures, which are the most common of all elbow fractures. They can be associated with ligament disruption and valgus instability. And the most common indication is a comminuted radial head fracture with instability. Other options include open reduction internal fixation or radial head excision. But it's thought that the radial head excisions can lead to valgus instability and then perhaps chronic pain or secondary osteoarthritis. So what is Dylan, what do you think I've got another patient actually as well. So radial head arthroplasties, the typical goal of them is to restore or prevent loss of elbow stability, improve the range of motion, and keep the radius out to length. There are some different ones that are described. We've got the silicone one here, which I've got a picture of. It's rarely performed. Now, I haven't seen any done at Imperial, I've got to say, Dylan, but there is the silicone replacement, but it's thought to be related to high rates of loosening, fracture, and also silicone synovitis. And this, you can see it on a radiograph as just this opaque shape of a radial head replacement. It's obviously not metallic, and this patient also has lateral ligament stability surgery. But typically they're composed of titanium or cobalt. They can be unipolar or bipolar, and the unipolar ones can be cemented or uncemented. Is that's correct, Dylan?
Yes, so I think that now that the latest generation of radial heads are broadly in 3 different groups. One is what we use, which is the anatomic radial head replacement. It's called anatomic, but it's quasi-anatomic because it's an estimation of the population, and it's very sensitive to rotation. So 20% of those loosen. It's in our figures, it's in the international figures. So it doesn't seem to really make them any worse, but they seem to functionally do well. But 20% radiographically loosen. So not clinically loosen, but radiographically loosen.
Yeah, so
I was going to say, sorry, and then then there's the other group, which are the axisymmetric, which is in effect a smooth polished stem that sits loosely in the stem, in the shaft, or in the neck rather, and the ligaments align it. So it's circular and the ligaments align it. And then the final is the bipolar, where the stem is fixed, but the head, in effect, the ligaments align the head, which is mobile. And nobody knows which is the best, and everyone has their sort of preferences, really.
Right. And so, yeah, because I read somewhere that you have a smooth stem, which is uncemented, and they expect a little bit of lucency around the stem because there's a little bit of movement, but that's thought to be normal. Is that right?
Well, the axisymmetric, they're just supposed to be loose.
Right.
And that's their design. These ones aren't supposed to be, these anatomic radial heads. It just doesn't seem to be that much of a problem when they do loosen, but we've only got sort of medium-term follow-up of it.
Right.
I said about 20% of ours look loose. But it doesn't appear to be a problem, and you wonder whether that is them actually, you know, the rotation isn't quite perfect, or the anatomy isn't quite perfect for them, and it's just loosening to an alignment that's better for them. I don't know is the answer. But.
Right. Okay, so this is just the bipolar one that you mentioned, which is, I suppose, has a hinge joint between the head and the stem, which allows better movement. But that's what the bipolar one will look like on radiographs. So just going on to the radial head replacement, we've talked about the possible complications certain that we have to look for as radiologists, whether it's dislocated. We've seen one example of that. They have got a propensity perhaps of secondary osteoarthritis because there's thought to be a reduction in the radiocapitellar contact area by about 68%, and this can unfortunately lead to capitellar osteopenia, and then you can get hardware complications, which I mentioned, which we talked about, loosening. So capitellar resurfacing we may see, again, I haven't seen this at Imperial, but again, this is where you have a cobalt chrome peg with attached to press fit concave spherical surface, which is used to prevent secondary osteoarthritis and prevent erosions of the capitellum. I don't know if you've had any experience of that, Dylan.
I think the biggest series is up in Derby, actually, of this, and it's called an LRE, I think, which is a lateral resurfacing something, I can't remember, but the guy in Derby's presented quite good results. I haven't seen one. I think I did see one done at Stanmore when I was there, but I think they've pretty much packed in doing them, so that might tell a story.
Right. Okay, so this is just another example of a 37-year-old man who fell from a skateboard directly onto his elbow. Again, you can see this intra-articular fracture of the radial head. He underwent a radial head replacement, as we can see here. Here the alignment looks okay. And then this is what we were talking about. So this is the 5th of September, but within about 2 to 3 weeks after, he's developed this lucency around the tip of the radial stem, which is about a couple of millimeters, which is obviously more pronounced than on his previous radiographs. But actually, again, I don't think he was doing too badly. So I suppose as radiologists, we can report the lucency, but clinically not entirely sure of the consequences of it. Okay, so this is just another example where we have everything, it seems, but this is a polytrauma. He's obviously got a markedly comminuted fracture of his radius and ulna. And so he had a radial head replacement. He has this olecranon plate with multiple screw fixation, but he has obviously, so he can't extend his elbow and he's got very little movement in his elbow. So marked stiffness. He's also got many other problems because he's a polytrauma, but he has fused his proximal radial ulnar joint. He's got extensive posterior heterotopic ossification extending from the distal humerus to the ulna. And I think he is one of your patients, actually.
Yeah, I mean, he is affected by HO. What we're missing here is we struggled to keep him in joint, so he had 2 or 3 operations. And the last one was to try and hold him in with a dynamic X-fix. And unfortunately now he sits in joint, but he hardly moves his elbow at all. So it's very difficult to take HO away here, but we might consider it.
Yeah. Okay. So just going on to another case. So this is a 52-year-old man who had a fall, 26th of April 2016, and he's obviously got a fracture through his distal humerus with intra-articular extension with 2 condylar components. And this is the coronal CT and the 3D reconstructions, which are actually quite helpful here. So this is just to illustrate the long stories of sometimes metal work with patients, because this started from 2016 and I just went through his imaging, but this was in May 2016, so he's had an open reduction internal fixation with medial and lateral plates. In July 2016, he was still not completely united. That's fairly early, but he wasn't united. But it also developed heterotopic ossification anteriorly. So that sort of seems a bit unlucky, really, where he's getting extensive ossification anteriorly, but he didn't unite the actual fracture site. So he went on to have a post-op arthrolysis. He had an arthrolysis and a non-union revision ORIF. So then moving on, I think that failed. So he went on to have a total elbow replacement. I suppose the problems were starting with poor bone stock. He's pretty osteopenic as well. And if we just look at this humeral replacement, the humeral component looks a little bit posteriorly inclined. And then you can see the ulnar component. So I talked initially, Dylan, about a total elbow arthroplasty at the beginning, but this is another one that we've looked at. So in fact, this was November 2016. And in fact, he's done pretty well, I think, for 4 years. And only now is he developing periprosthetic lucency around the humeral component and also the cement bone interface. So whenever we see the lucency, we've got to be thinking septic or aseptic loosening. And this patient also has a prominent elbow swelling. So he had a collection overlying his olecranon. It was about 3 centimeters. It was extending up to the joint. So we were asked whether we could aspirate it, but actually it was real thick synovial tissue or soft tissue rather than an effusion or collection. So he underwent a biopsy in August, and in fact that showed metallosis and didn't grow any bugs. So that was sent for obviously microbiology, a metal analysis. So that showed metallosis. He had a SPECT CT, which shows quite a lot of osteoblastic activity at the humeral component and also the ulnar component. So although we didn't pick up infection within the soft tissue, we were certainly worried that this could still represent some element of infection. So that is a fairly complicated case. And I mean, I suppose it's just to illustrate the fact that, you know, this patient presented with a trauma, he's had a non-union, he then had heterotopic ossification, he's also had an elbow replacement, and now he's got either septic or aseptic loosening and particle wear disease, even metallosis. And so it's spanned over 4 years. So it's interesting that, you know, many of these patients end up having quite a lot of imaging.
The entry point for this elbow replacement, for the ulnar particularly, isn't right. And that might be dictating to a degree because it's linked, dictating what's going on in the humerus as well. The entry point needs to be far more in line with the canal
Right.
Of the ulnar.
As in here, you mean?
Lower down, yeah. So you have to take away some of that olecranon fossa to get your entry point.
So it's actually more parallel with the ulnar.
Yes, exactly. That's how it should be. I think you always get a tiny bit of inclination, but it's not normally as much as that.
Right, and therefore that's affected this and the humeral component.
But I think for those at this trust, we won't be seeing many elective elbow. We'll still be seeing elbow replacements for trauma, but elective elbow replacements, because they're all being consolidated to certain sites now. So the rheumatoids and that kind of stuff, you probably won't be seeing many at this site. So there's only really, I think, Stanmore and Guy's that are going to mostly do those. Right.
Okay. And in fact, I did show one of them that I think was done for psoriatic arthropathy at the beginning.
Yes. Yeah.
Well, I can go back to that quickly, actually, so you can just have a look at that, because I've got only one case after that, I think. So this was the one that, sorry, going back. Yeah, this was the one that was done for psoriatic arthropathy. I don't know if you wanted to add anything for that. That was
no, it's a shame I can't do them anymore. It's not a huge lot. I mean, it is probably right. You know, I would do 1 or 2 of these a year, and that's probably not enough. Whereas, you know, shoulder placements, I'm doing over 30 a year. So it's probably right. But this was a very good solution for this lady, and she has no triceps really. You can imagine from what we had before. So
I'm going to go back to that.
Yeah,
that was 2015, and then she progressed to that 2018. Yeah.
Her triceps were like a film of fascia there. They weren't like proper triceps at all. But she's got an elbow that no one really wanted to touch, and she's doing all right now. So, but it's not actually with a linked elbow replacement. That is not hugely difficult to deal with. So, you know, because you can forget about most of it and just get a stem up the shaft, stem in the ulnar in the right place, and you're okay.
Yeah, I mean, this one, like you were saying, is much more parallel to the ulnar, isn't it? Yeah. Okay. I'm just going to flick through my slides. Sorry, back to the other case.
Dylan, are our triceps bigger now?
I send her off with my other patients, and they're much bigger now.
She's starting triceps dips. Okay.
Lockdown exercises.
Yeah.
Okay, so this is just one I wanted to end on in terms of positivity, I suppose. So this is a 37-year-old female, polytrauma, fractured distal humerus radius and ulna, not dissimilar to some of the other things we've seen, but you know, we're a polytrauma center, so or major level 1 trauma center, so we get quite a lot of these sorts of elbows. So this patient underwent an open reduction internal fixation and also wiring through the olecranon, and you can see actually quite a big bony gap there, but a year later she's completely united, and she did very well, I think, from looking at her notes. She seems to have done really well, so completely united and not had a problem.
It does. It should. So I had to take that bit of bone out. It was a completely loose bit of bone,
Right.
and everything else was aligned, but I didn't know if losing that much. But the idea with this technique with the medial and lateral plates is that it can deal with metaphyseal comminution very well. It's the strongest construct for that. And yeah, so she's grown new bone. Now she is only, you know, relatively young and stuff like that. And whether you'd get that in a more elderly patient, I'm not sure. But it does seem to happen. And I think, you know, it's metaphyseal bone. The turnover of metaphyseal bone is much higher. So, you know, because realistically, what we've done here and what you've seen in all these fixations, you could never do in a tibia or something like that, a long bone fracture, because the turnover of the bone isn't the same in the surface area. So all the rules that apply about working length that we use to try and fix fractures don't really apply in this. You just hold it rigidly with as many plates as you want, pretty much, and they'll heal. So yeah.
So Dylan, just for everyone else, is this the bit that you're saying is filled in, where I've drawn the arrow?
Yeah, I mean, it's really remarkable, isn't it? Because if you start with that and you end up with that, it's done really well, haven't they? I mean, I suppose the decision making at this point, Dylan, for you, whether it would be a total, you know, like a hemiarthroplasty or this fixation, I suppose it's the age and the fact that if you put enough.
Almost completely age, really. I mean, I'm always going to have a go at fixing them at that age because even if they're in multiple bits, those bits have some integrity normally in younger people. So you can make an effort at putting them back together. Whereas, you know, in the elderly, you've just got no chance, and because of their age, you can go to a hemi. And I think the hemis do quite well now. You know, I've got most of the people I've done hemis on. I have got some where they're not quite right, but most are back swimming and all these kind of things. So
I mean, that was it. I just put out a selection of cases. So just in summary, you know, outcomes may be unpredictable, and I think it's, you know, we need to look at the metalwork and see what's happening, and obviously have a good conversation with your surgeons. I think the elbow joint is, like we've talked about, very susceptible to heterotopic ossification. So some of these patients will present with stiffness and reduced range of movement. But yeah, liaise closely with your surgical team. And I was just saying at the beginning, Dylan, that, you know, we see probably less elbow metalwork than we do hips, knees, shoulders indeed. So yeah, I suppose it's about liaising with your surgical team about those cases.
I think, yeah, there's a couple of things. I mean, synostosis between radius and ulna, we probably are poor at picking it up ourselves, and so if you think there's a synostosis, sometimes we've been quite slow in picking that up. And even that makes me think the biggest problem guy I've got, who's going to have probably his fifth or sixth operation, and we've discussed ad nauseum in the MDT, was a guy who had a missed dislocation in Bali, and after falling off a moped, where they fixed the rest of his injuries but not that. And then he came back, and I remember sitting in an MDT meeting, and I was going to try and get him centered and do the things I would normally do for a dislocation, but was aware it was delayed. And I think it was Minnie who said there was some eight heterotopic ossification at the front of the elbow, and I sort of dismissed it, but actually I wished I hadn't, because it caused me no end of problems and has been probably the central issue with me trying to sort him out. And the problem is, if you're not If you don't know about it beforehand or don't take notice of it beforehand, then the x-rays we get in theatre are much worse than what is available here. So you often can't see it in theatre. So you've almost got to know it's there beforehand. And I think if I'd thought more about this case, the one I'm describing, then the approach would have been very different.
And that's so that's across the proximal radio.
Yeah, so HO generally is a problem and it definitely needs flagging up if you see it, I think. But also synostosis is quite difficult to see on X-rays. And we often sort of your eyes aren't naturally drawn to it, I think. So that's one of the things definitely to look out for as well. Anytime there's sort of ulnar trauma, you know, big ulnar trauma, the chance of them getting a synostosis is pretty high, I think.
Thank you so much, Monica and Dylan. It was really, really great. The cases were amazing. I think it's a representative amount of cases of the type of pathology we can see. I wonder if there are any questions for the audience, for Monica and Dylan. Feel free to just unmute yourself or just put it in the chat. I actually have a question regarding how do we assess the alignment. In one of your cases, Monica, I think there was the case of the lady that the fixation failed, and then she underwent a total elbow replacement, where the humeral component look a little bit, that one, yes, this one. So here, how can we assess the alignment here? Because the humeral component, as you mentioned, looks a little bit like posterior. Is that a normal alignment, or what are the references in this case for checking the alignment in X-rays?
So, Dylan just mentioned actually before that actually, in hindsight, probably this ulnar stem component should be more parallel with the ulnar itself. So it's kind of at a slant, and because of that, this is tipping probably posteriorly, but actually the humeral stem should be in the center of the diaphysis, centrally within the diaphysis. Is that correct, Dylan? I'm speaking for you.
I mean, I think they're probably both a little bit wrong. But it is hard to see when you've got something linked. But normally they would cement the humerus first. So whatever alignment they've got should be independent, really, of the ulnar. And I think their entry point needed to be a little bit more posterior for the humerus and a little bit more posterior for the ulnar as well.
So more here.
Yeah, exactly. To get the ulnar, you do have to burr away quite a bit of the olecranon fossa to get your entry point right, such that if you're seeing the normal curve of an ulnar, you're probably not in the right place. It's got to almost look like it's been really flattened out.
Yeah.
But if you look at the shaft of the humerus and the shaft of the ulnar, the entry point should be in a line with the middle of that, really.
Yeah. I suppose a bit like this one, the one we saw before, going back, the one the psoriatic arthropathy case.
Yeah.
Plasty. Sorry, that was that one. I'm going back there.
Yeah. So actually, you could say I'm a little bit anterior on the humerus there as well, but I think the ulnar looks about right. And you can see you've got less ulnar there. Now I know she's very eroded anyway, but that's normally what you see, that amount of ulnar beneath the prosthesis.
Yeah, here you mean, yeah.
I had something else to say, but I can't remember what it was now. Go on. Can't remember.
So Dylan, on this image, you see that the hook that's part of the humeral part of the prosthesis. Is the anterior cortex meant to fit in that loop?
No, you're supposed to put a separate fragment of bone there. So when you've excised away all your articular surface, you take a slice of bone and put it in there if you want. Some people don't think it's worth it, but that was how the prosthesis was designed. the commenting on positioning, it's always difficult, isn't it? Because you know, people take offence, don't they, if they say that the positioning's not right. I don't know really how you get around that. Yeah, I think probably just to prevent internal conflict. It's more sort of, you know, saying whether they look loose or something. You know, it's fine to say if it's sort of inclined against the posterior cortex or whatever, but people often take offence at saying they're not quite in alignment.
I've got a question from one of the radiographers asking, from a radiographer's point of view, what can we do better in terms of positioning for the elbow?
I don't know is the answer. As to how we position for radiographs, I'm not sure. I mean, we want, with an elbow, we generally want a true AP, sorry, an AP of the elbow and a true lateral of the elbow. One of the issues we nearly always face is the fact that they very rarely can straighten their elbow fully, certainly in the early times. So it's angling the beam to get a true AP of the humerus, if it's a humeral issue, or vice versa if it's the ulnar, because they can very rarely straighten out fully. But that's all I've got.
I mean, I suppose the only other, just mentioning that Coyle's views, I thought is very useful for the radial neck fractures, but
yeah,
I mean, that was the only one I thought that's quite useful that we see sometimes.
I mean, I'll normally go to a CT with a radial head, if I'm honest.
Yeah.
Unless it looks undisplaced, I will go to a CT, and you can normally, whichever view, you can normally see it, whether it's displaced or undisplaced, and then you go to a CT.
Yeah.
I think there is one question here. So in summary, when reporting metal work on the elbow, the most important complication will be heterotopic ossification, lucency, infection, and alignment. Anything else we should look at?
Obviously subluxation and dislocations, I mean, that's part of alignment. I think, again, comparison with old films is always so important. You know, make sure that you do, you know, you compare with the old films.
Yeah, I can't think that there's a huge lot more. It's amazing how sometimes we obsess with what we think we're looking at, and so, you know, if you do think plates are significantly displaced or something, I think you've got to report that, because, you know, it's, for example, I did a case yesterday with the registrar, and I was just about to walk out the room saying that the position of the clavicle's fine, and he hadn't really located where the AC joint was, and so it was sitting just miles across the AC joint. So with me about to walk out, we then had to revise the entire fixation, take everything down and redo it. And so sometimes, you know, just reporting those obvious plate displacements where they don't look right is quite useful, because it's amazing how you can look at what you think you need to know, but not looking at the most obvious things sometimes.
Yeah, I think that's really useful as radiologists. We're kind of the sanity check to say, hey, have another look at this.
Yeah. And because you're not biased. So.
Yeah. I guess one other thing I could add is that sometimes it's good on plain films to look at the soft tissues. So Dylan was talking about that case with the triceps wasting. You can look to see if you've got a reduction in the soft tissues on that side. I mean, this patient here, you can see he's got good muscle function. You can see good muscle bulk on the plain film, but don't forget to look at the soft tissues.
I would like to know why the metalwork needs to be removed when there is an infection, or put a new one.
It doesn't always. You can suppress it with antibiotics, and fractures can heal, but they're a breeding ground for bugs, basically. and fractures very rarely heal in the presence of infection. So whereas it's quite or relatively easy to eradicate infection from a native wound, trying to eradicate it from metal is almost impossible without removing the metalwork. So that is why we do it, because the bone won't heal in the presence of infection, and you won't be able to get rid of the infection without removing the metalwork, because it's such a good host for the bugs.
Thank you, Dylan. Okay, so I think that's all for today. Thank you for joining us, and I hope you enjoy the session. Next we have Monday and Tuesday, so we hope to see you there. And thank you again to the speakers.